So instead of just you heard a lot of things, a lot of technology that gone through, and we are coming to the refractive. Basically, the cataract has become a refractive surgery now. Anyhow, the refractive surgery survives, and there are a lot of changes which keep on coming back to, and the latest one is the coming back to surface. That is a great leap forward. Basically, the refractive surgery started as RK, then going through various phases to SMILE, Contura, and advanced surface ablation. That's the latest addition. So earliest was the PRK. It was more accurate. The myopia, hyperopia, and astigmatism can be corrected compared to RK. Then it was more stable. The problem was it was having pain, delayed healing, and scarring. Then came the LASIK. Rapid recovery, wow factor, decreased risk of scarring, no pain, flap stry, buttonholing, but that's the complications like flap stry, buttonholing, partial flap, debris epithelial growth, DLK and late trauma, and of course the ectasia were associated with this thing, but it was not very common, and LASIK became a very popular surgery. Then came the femto, which made safer flaps. They are thinner, they were planar flaps, and the fewer incomplete or buttonholing was there. But some problem with these also persisted, like some have photophobia, some rainbow effect, higher DLK, late trauma can dislodge it, and ectasia can occur even after the femto. Then came the SMILE, a very good procedure and doing very well now, but there is some limitation. There is no hyperopia correction at present. Customized treatments are not possible. Difficult in low power correction, you have to take a lot of tissue. Bitoric, mixed astigmatism are difficult to treat. Treatment is centered on the pupil. Cyclotorsion compensation is not available in the standard machine, but things are being tried now. And you have to remember that little decentration in the LASIK will not affect. But SMILE, even a little decentration can cause a lot of problems, and high comma aberrations are quite common in these days that may persist even up to 6 months. Then coming to the indications of ASA, irregular astigmatism, thin cornea, night vision concerns, anterior stomal opacities, the contact sports or their chances of more injury. If there is prior RK or AK, if you want to do customized treatment, if the eye is have been subjected to RD surgery or there is a filtering blab, deep set eyes with prominent orbital roof, you can't do all these procedures. Here the ASA scores over LASIK and SMILE, and you can combine it C3R also. So PRK has shown to be the safest procedure as far as ectasia is concerned. So there's a lot of literature available which shows that probably is the safest, and the chances of getting ectasia are least in advanced surface ablation. Of course, it can occur in any eye. We can combine it PRK, making the cornea more regular and make the cornea more susceptible to have contact lenses or better vision. Coming to the PRK, it was earlier local anesthetic drop, manual or Amoyal's brush, or the various techniques to remove the epithelium. The epithelium is removed, laser is applied, and mitomycin is placed there. This is the standard treatment, what we are following for the last few years, putting a bandage contact lens, antibiotic lubricants. So this is a very simple procedure. You have to aim the laser, fire it, and put the contact lens on it. The complication which were common earlier was stomal scarring, irregular astigmatism, persistent corneal epithelial defects, recurrent epithelial erosion, which may cause significant discomfort, and even epitheliopathy. So these has been taken care now by various means. First is the improving results, and you have to look for the hygiene. If any problem is there, you have to treat it first. Because of shortest time, I will not cover each one of them. In operative, mitomycin has changed a whole game. And we are using even CL soaked with AccuWell or AccuSet for reduction of pain. Newer, stronger and painkillers have come. Then mitomycin C is probably the game changer. It's a potent antimicrobial, inhibits DNA, cellular RNA, and protein synthesis. It blocks keratocytosis activation and results in preventing anterior stomal scarring. So at present, we hardly see any scarring there. And post-operatively, there are a lot of things. We are using oral good quality pain agents and avoid aminoglycosides in, and provide good nutrition also to these patients. That help a lot. And the most important thing is avoid UV exposure. That means using good quality of goggles. I myself give it to patient. don't ask them to buy from the market, because many of the goggles which have UV blocker may not be probably perfect one. But again, the newer things which have added on is the handling of the epithelium, which has changed the game again in favor of advanced surface ablation. It's a smart surface technology by Schwind. Then Streamlight, this is from Alcon. It has come with one step, no touch, no blade, all laser technique. The difference with the PTK earlier procedure we were doing is, here the epithelial removal is wavefront optimized. That means this is a PTK neutral, unlike the PTK we were having earlier, and it's a wavefront optimal profile, which gives the best results, and it's become a one-step procedure. So the range is again as good as you can think of LASIK or SMILE. The official recommendation is up to -10, but people are doing even 12 or 13 diopter, especially in the LVP, they are doing a good number. And we can correct hyperopia up to 3 diopter. We can correct all sort of astigmatism also with this one. And it's a one step, there's a no time lag. First epithelium is removed, followed by refraction correction done, optical zone selection, which corresponds to refractive zone. There's a less myopic shift compared to standard PRK mode. There's a optimized epithelial removal, and it's a uniform removal. There's no island of epithelium there. So epi-ablation zone automatically retained by the laser based on the PRK ablation profile. There is an active eye tracking throughout the entire process. Just to sum up, accelerated healing and visual recovery by limiting minimum epithelial removal. We just take whatever is necessary. There's a less pain and there's a reduced risk of haze because of accelerated healing by smooth surface and better contour, by removing damaged cells and reduced thermal effect. The shortcoming at present is, the flip side is that it accentuates the importance of having an epithelial mapping. It causes more heat. It's still not available with customized treatment, and it has a price tag. So overall, the advantages are, it's a gentle, no touch, no cut, no incision. The recovery is very smooth. Even after 12 hours, you can see the patient is reading very well. It's very safe. There's a more mechanical preservation, and there's a corneal stability. It's a stress-free. There's not a learning curve. Anybody can do it on the day one also. It's a faster treatment in a single step. No cut, no cap, no flap, etc. there. It's excellent clinical outcome. It reduces dry eye by leaving the nerves that produce tear intact. Can be combined with CXL. It's economical. You don't need the femto or other things. So just to conclude, why it's become popular and come to the mainstream. It's a better examiner profile now we have got, finer flying spots, mitomycin C is the game changer, and better epithelium removal, causing wavefront optimized epithelial removal. These things have made the advanced surfaces to come back again the mainstream. Thank you very much.
Thank you very much, Dr. Vinod Arora. You have beautifully explained this resurgence of surface ablation. I think it's a fantastic technique that's there. But I normally don't prefer to do a power more than -6 on surface ablation. I don't know what others.
So my personal experience, I have done up to -10 very easily. 10, okay. There's a total spherical power, and there is a good number of cases.
We also limit to 6 only.
6?
Yeah, 6, yeah.
Okay. Ram? 6? Okay. 100 microns would be 13 into 6 would be 78, yeah. Okay.
So
okay, fine.
Anyhow, I'm getting good results. I'm doing it well and very well satisfied. Even the Alcon recommends up to 10 diopter. That's a... that's thing.
Fine.
Even they are doing 13 or 14 diopter also.
So I don't
and
know,
getting good results.
No other form of refractive surgery has taken out in, taken ground in LVP as things stand. Anyway,